So I'd like to start off in a good way. I'll reintroduce myself. I'm Tamil Kendall. I'm the director of the Partnership for Women's Health Research Canada. And I'm joining you this morning from what is colonially known as Victoria, which is on the traditional territories of the Lekwungen-speaking peoples, the Saanich, the Esquimalt, and the Songhees First Nations. And I would like everyone to take a moment to think about the traditional territories and the Indigenous peoples and First Nations of where you're joining from today. So we'll just take a moment to really think about our gratitude for being on these lands. I'm delighted to be here with you to start out this January 2024 with a topic that is very close to my heart, patient-centered research methods as well as patient-centered care, and to have two fabulous speakers with us, Dr. Dana Ross and Dr. Hélène Côté, to speak about a training initiative that's underway to improve healthcare providers' capacity to deliver trauma-informed care, and also a long-standing and really exciting suite of research that happens in Canada that it really integrates women living with HIV in the design and execution of that research. So I'm really looking forward to this session, very excited about it. Just so that you know a little bit about POWER. POWER is an alliance between the Women's Health Research Institute in British Columbia, the Women and Children's Health Research Institute in Alberta, the Women's College Research Institute at Women's College Hospital in Toronto, Ontario, and IWK Health in the Maritimes. And we've come together with the vision of better health for all women, trans, and non-binary people through research excellence, equity, and inclusion. So we really exist to support health research that focuses on women, trans, and non-binary people, and to help get both the methods and the results of that research out into the world. So with that as an introduction, I would like to introduce Dr. Dana Ross. She is a psychiatrist and also a clinician educator in the trauma therapy program at Women's College Hospital and an assistant professor in the Department of Psychiatry at the University of Toronto. She's leading two research projects that will expand access to treatment for complex trauma in Ontario, and another project, which I think is the focus of her talk today, about providing virtual education on trauma-informed care. In her clinical practice, she provides trauma-focused group psychotherapy to adults who have experienced childhood interpersonal trauma. She's really passionate about healthcare innovation, virtual healthcare solutions, and relationship-centered care. As a First Nations physician, Dr. Ross is a mentor through the Diversity Mentorship Program at the U of T and an advocate for trauma-informed care. Welcome, Dana. I'm really looking forward to your talk.
Thank you so much for that introduction and for everyone for being here. I'm just going to share my screen here. Perfect. Okay, so as we heard, I'm going to be talking to you about transforming healthcare through asynchronous or self-paced trauma-informed care education. We'll do a really brief overview and talk about one study looking at two of the phases of that study. So no conflicts of interest to declare. The objectives are to describe 6 fundamental principles of trauma-informed care, name 4 issues of concern with some of the current literature on trauma-informed care, and describe the 2 phases of our TIC study and emerging results. Start with a big number here. This is a number that comes from the StatsCan data from 2021, where they report that 60% of Canadians have experienced trauma at some point in their lifetime. So this is a big number and a big figure, and it really is an important one to hold as we're talking about trauma-informed care, because part of the impetus of trauma-informed care is that acknowledgement of the prevalence of trauma in our country at large and in different groups in the country as well. Now, let's juxtapose that between this number of 14% of healthcare providers that feel adequately trained in trauma-informed care. This number is coming from some of the research I'm going to talk to you about, where we sent out a survey to healthcare providers, and we got 106 responses. And this is what we found in terms of how people felt their preparation was and how confident they felt about their training to date. So a big discrepancy between that 60% and that 14%. Just a really quick overview of trauma-informed care. It's about recognizing the intersecting health effects of structural and individual violence and other forms of inequity. Also, it's about understanding people's health and social issues in context. And a very important part is about working to reduce re-traumatization. SAMHSA, which is the Substance Abuse and Mental Health Services Administration, 6 fundamental principles of TIC, are what follows. They have a great, if you look up their website, if you're interested in more trauma-informed care resources, they've kind of been in the field of trauma-informed care for a while, so they've got lots of great handouts. Also, a lot of great resources around implementation of trauma-informed care, and we're going to hear, as I tell you about our work, how that's a really big piece and a piece that we'll be focusing on a lot. So the 6 principles are around safety, a feeling of safety, and that's not just for clients, patients coming into the healthcare system, but also for ourselves and our colleagues who are working in that system as well. Trustworthiness and transparency, peer support. Again, not only the peer support, client to client, patient to patient, but also what's the peer support that we can provide each other as colleagues as well? What does that look like, both at that individual colleague to colleague level, but also at that organizational level? Collaboration and mutuality, empowerment, voice, and choice, and a sensitivity to cultural, historical, and gender issues. So let's take a moment and differentiate between trauma-focused versus trauma-informed care. So trauma-focused care is generally thought to be anything that's really focusing on the actual impact or symptoms of trauma. So someone who's working with people who have a diagnosis of PTSD, or in the trauma therapy program at Women's College, we work with people who have childhood trauma, and we're doing a lot of group-focused therapy, looking at the impact of that trauma on their here and now day-to-day lives. So we're doing trauma-focused care versus trauma-informed care, which anybody and everyone can do and be a part of and participate in. Trauma-informed care, we're going to focus on it in terms of healthcare, but you can really look at it outside of that. Not long ago, I was reading a really interesting paper on trauma-informed architecture, for example. So you can really pull this out into a broader way of understanding as well. There's amazing literature on trauma-informed care, but a couple of issues, just as we're talking about the work that I'm going to talk about in particular, is that many studies on trauma-informed care curricula are pre-pandemic, and that's great. The problem for us is that as we try and do virtual, asynchronous, or self-paced curriculum building, that sometimes it's hard to take that in-person seminars and the in-person workshops and take that curricula forward. So that's just something that we're noticing as we're looking through the literature. But certainly in the last couple of years, there's definitely almost like an explosion of trauma-informed care literature. I was looking through it again last night as I was just preparing and feeling very impressed with all the stuff that's coming out. It's quite exciting. Many studies on trauma-informed care education evaluate small, discrete groups. So for example, there's studies looking at how do you build a trauma-informed care course for emergency department nurses or respirology residents. And again, that's fantastic. But if we're thinking about taking a curriculum and scaling it at a larger level, that can be a little bit challenging to do based on what's available there. And again, a lot of it looks great, but sometimes it hasn't been researched or formally evaluated. I was looking at, I think it was Alberta Health Services had a fantastic curricula all mapped out, and I was looking at that recently, but I couldn't see if it had been evaluated or researched, so that was a question mark in my mind around it. Studies do not include all healthcare staff and focus on healthcare providers to the exclusion of admin and support staff, and I'd say this is one of the bigger ones that I've noticed. And from a research perspective, makes a lot of sense in terms of, people's budget is limited, resources are limited when we're doing research. And so we're kind of focusing on a particular group. But we step back from that and think about the whole concept of trauma-informed care. These are universal principles, that trauma-informed care isn't just about the individual healthcare worker, but also about the organization and on that systemic level. And so it's hard to say we're going to put forward an education program in healthcare that's just for healthcare providers and doesn't include everybody who works in that hospital system. So that's one of the things that we're looking at in the second phase of the study that we're doing. And I always just have this slide just to remind me, in case I haven't said it, because it's so important, that trauma-informed care is not just for individuals, and organizational involvement is really, really key. So let's talk about the work that we're doing here. So this is a study that's on transforming healthcare through trauma-informed care education, and we started with a needs assessment. So we're going to look at phase 1, and then we'll talk briefly about phase 2. It started because we, as a program at Women's College Hospital, were getting a lot of requests on, can you come and talk to us about trauma-informed care? What does this look like? Can you consult as we try and implement this into our program? And because we're kind of a small program, we just don't have that capacity. And like everywhere else, we have really long wait lists. So to pull away from that clinical work creates that kind of tension inside as well. So we thought, well, we'd love to do something in this space. And a lot of us are really interested in education. So what if we were to build a virtual asynchronous or self-paced course for healthcare providers? But first of all, let's pause, as we always should when we're doing this kind of work, and say, is this actually needed, or is this just something we're passionate about and we want to do? And so we said, let's dive in and figure that question out. So the problem is that psychological trauma is really common among patients, clients, healthcare staff, and yet the healthcare system lacks training for healthcare providers on trauma-informed care. Really important to draw everyone's attention to that part about the healthcare staff as well. We know that there's a high prevalence of trauma in the Canadian population, among patients or clients, but also among colleagues and among people who work in the healthcare system. And so when we're thinking about trauma-informed care, we're thinking about all of that and all of those folks. So the gap, a lack of easily accessible, affordable, scalable training for healthcare providers on trauma-informed care. And this is sort of the gap we saw when we were doing this first phase. We changed when we're moving into the second phase, what I'll tell you about, we expanded beyond healthcare providers to everybody who works in the hospital. But in this first phase, it was kind of narrow, and we're kind of focusing in on healthcare providers at first before we realized to ourselves, like, oh no, we want to pull back and have a broader view of this. So our solution for phase 1 was to conduct a needs assessment to evaluate attitudes, barriers, facilitators to a virtual asynchronous course on trauma-informed care. We got funding from the University of Toronto Department of Psychiatry Excellence Fund for this. We really hypothesized that multidisciplinary healthcare providers at 2 urban hospitals, we did this at Women's College Hospital and at CAMH, which is also located downtown Toronto, would be interested in receiving more training in TIC, and that they would find a virtual asynchronous format acceptable. So what we did, how we approached this question, is we started with this questionnaire, an anonymous questionnaire that we sent out to healthcare providers. And we had 106 people reply. You'll see we looked at nurses, social work, psychiatry, psychiatrists, and then it says, oddly, it says kind of other here. And this is a good learning for me and my team as researchers. So we thought, okay, we don't have a very big budget. Let's kind of keep this really focused and kind of tight. We'll just pick these 3 groups. We'll do the questionnaire, and then we sent the questionnaire, and we really realized quickly, people aren't like super jazzed to like fill out a questionnaire. It's hard to get people to fill out a questionnaire. So then we backed up and said, let's open this up to as many healthcare providers as we can, and really appreciate that getting people to really fill out questionnaires is actually quite hard in research. And so I have a lot of respect every time I see a paper where someone's done a questionnaire, that does take some effort. Number 2, we did some semi-structured interviews with 28 folks that were conducted between patients, healthcare providers, and key stakeholders, primarily leadership folks in the hospitals and in education. And we asked both in the questionnaire and then in the individual interviews, what do you think about trauma-informed care? How comfortable are you with it? What kind of training have you done? Are you interested in learning more? Would you be interested in a course? Would you be interested in a virtual course? And so we're asking all of those things, and what topics are really important to you. After we did that, we then put all of that information and we did an initial curriculum outline, which I'll show you. And then our next step, hopefully in the next couple of weeks, is we're going to send that outline out to the folks who did the individual interviews and get some initial feedback, and that will close out our phase 1 for us. In terms of the questionnaire results, the biggest category there was the 37.7 other, and then nursing, social work, and then finally psychiatry. And this is interesting. When we very first started looking at some of the information that was coming in, it said 87.7% of healthcare providers have received some training on trauma-informed care. So at first we thought, just seeing that, oh, well, good thing we did a needs assessment. Maybe we don't actually need this intervention, right? And so that was a moment. And then we kept looking into the remaining results, and we found a different story. So it's always interesting looking at how you phrase questions and how you interpret the data. But what we found really is that although people had, by and large, like the vast majority had some training on trauma-informed care, the vast majority also felt they wanted more training, and also, what do I do with this? And that the issue of translating knowledge into practice is a big gap here in this space. And so that's something we're really, really trying to think about as we move forward to building the course. So we talked about how relevant and important is trauma-informed care in your role or area of practice. And you can see that 81.1 said it was very important, 15.1 somewhat important. So we were happy to see, that people did feel this way, which aligns with what we were hoping and feeling. We asked also, how would you rank your level of interest in taking a virtual course on trauma-informed care? We also asked, how would you rank your level of interest in taking a course just without the qualifier of virtual? And they looked virtually identical. So that was good to know as well, that a virtual course was an acceptable sort of format for folks. We also said, what are your top 3 topics? What do you want to learn about the most? What are the hottest things for you? And number 1 was how to ask about trauma and respond to patient disclosures to reduce the potential for re-traumatizing when delivering services. How to incorporate principles of equity, diversity, inclusion, and belonging into trauma-informed care practices, and including performing culturally sensitive assessments. And then 3 was trauma-informed care skills and strategies for general use in day-to-day work. And that, again, really echoed in the qualitative data through the individual interviews, people saying, help me do something with what I've learned. And so that was loud and clear. We won't go through this, but just to give you a little bit of an idea of what that final course outline looks like. We have 9 different topics. We have learning outcomes and then learning objectives. And so we did this initial draft, which we'll be sending out soon to those who participated in the interviews. And despite having received training in the past, this is the conclusion, most healthcare providers would be interested in taking a virtual self-paced course on trauma-informed care. And that participants really felt unsure, again, of how to apply what they'd learned to their day-to-day practice. This brought us into phase 2. Which is about the development and evaluation of the course. Phase 2, we're just starting. It's going to last 18 months. We got funding through the Women's College Hospital Breakthrough Challenge. We're going to build out that curriculum into a very detailed thing. Then we're going to send it out to patients, healthcare staff, and also healthcare providers who have expertise in trauma, different types of trauma, to get their feedback on that curriculum. Then we'll design and develop it, and then we'll evaluate using pre-post questionnaires and focus groups as well. Our whole kind of goal of our research program and my passion personally is about scalable trauma-informed care education and how we can make this something that we can build. So we're really thinking about modules, and can we build this in a modular fashion so that there's this core universal cluster of topics, and then maybe in the next phase 3, if we get funding for that, we can start to build unique modules on top of that, either about specific groups or specific types of trauma and what have you. This is my amazing research team. So everybody is really active in all parts of our research. And some resources on trauma-informed care that I've found helpful. some references. And I think that brings me to 20 minutes. So thank you so much for listening. And I think we have time for questions. I think I'll stop sharing now.
Thanks so much, Dana. Anyone is welcome. We'll have a very punctual break here. If you have burning questions or clarifications for Dana, we can take those now. You can either put them in the chat and I'll read them out, or you can put up your hand and unmute. If there aren't any, we'll move on to Dr. Côté's presentation, and then we'll have a chance for broader discussion at the end of the panel. But I do want to see if there are any specific questions at the moment. It doesn't look like it. So thank you so much, Dana, and we'll talk in the panel discussion in more depth. So now it's my pleasure to welcome Dr. Hélène Côté, who holds a PhD in biochemistry and is a professor in the Department of Pathology and Laboratory Medicine at the University of British Columbia. She's a member of the Women's Health Research Institute and the Center for Blood Research and the Edwin S.H. Leong Centre for Healthy Aging. Her research, which she's going to speak about, focuses on the effect of HIV and antiretroviral therapy on aging using both human cohort studies and in vitro models. And I have to say that I'm just fascinated to hear about how women living with HIV are being engaged in this very biomedical and clinical research. So welcome, Dr. Côté.
Well, thank you, Camille. I will try to share my screen. I don't know if I have managed to do so. Are you seeing my slide?
No, not yet.
Okay, just a moment. I'm confused. I'm not seeing my slide. Let me try something else. It worked earlier.
Yes,
So,
this is always the fun thing about technology. We actually did a chat.
yes, we did.
As we started. Maybe I do have a question for Dana while Hélène, or more of a comment. I guess you're planning really extensive testing or validation in the second phase with wide groups of people. Is that mostly being done asynchronously as well, or is there are you doing focus groups and that kind of face-to-face work?
Yeah, thank you. We're going to do both. We wanted to do the asynchronous pre-post, which will just kind of get us straight up responses, but we're going to do focus groups with those different groups of people who do the course as well, because we wanted to see if there's any real differences between them. So we're actually meeting with a stats person soon to just get those numbers, or how can we get the numbers? What are the numbers we need to really meaningfully compare those groups?
Interesting. Thank you. Okay, over to you, Hélène.
I'm hoping you are now seeing my slides. Are you?
We are seeing your slides beautifully.
Okay, yeah. Thank you. Okay, thank you for inviting me today. I will talk about the BCC3 experience with community-engaged research on healthy aging in women living with HIV, and I am really presenting this on behalf of our team. First, I'd like to acknowledge that I live and work, and the most of this research was conducted on the traditional, ancestral, and importantly, unceded lands and waters of the Coast Salish people, and these include the Tsleil-Waututh, the Squamish, and the Musqueam nations. So I thought I would present an outline because I'm really talking about this research really from the point of view, well, my own point of view in a way, being a basic scientist, embarking in community-based research was a bit of a leap, something that I did not have prior experience in. And I thought this could inform other people who may be contemplating doing this. So I want to talk about why we felt that this research needed to be done. I will describe what the BCC3 is, the timeline that this type of research has taken, the training and the role of community research associates within our team, how we engage with community from study design to publication and presentation, KTE, and some example of data presentation, but I will not really go into our results given the time constraints. So why did we need a study like this? Well, more than half of all people throughout the world living with HIV are women and girls. And in BC, they represent approximately 18% of people with HIV, and an even higher number of the new diagnoses in Canada are women. And with antiretroviral therapy, which is a highly effective, women living with HIV are getting older, as are most of the people with HIV, but they continue to have shorter lives than men with HIV or than HIV negative women. They also, importantly, have a shorter health span, meaning fewer years in good health than those counterparts. And so really that was, not only upsetting, but the question was why? And if we look at research in this area, less than 8% of all published HIV research is actually women specific, and actually much less than that if we don't consider the literature that is about pregnancy. And so we felt that to promote health equity, a women-centered research approach on healthy aging was really needed. So this was the culmination, or the joining of two large Canadian cohorts that were existing. The first one was KARMA, which I was the principal investigator for, that studied women and children and the effect of antiretroviral therapy on markers of age. And the second was CHIWOS, which was a large Canadian HIV cohort study on women's sexual health and reproductive health. And so we took the biochemical and clinical perspective of the KARMA cohort, as well as the fact that it had negative controls, and the social, structural, and community-based research strength that CHIWOS had. And together, this came together to be the British Columbia KARMA CHIWOS collaboration, a community-based, holistic approach to study aging and health in women. And I will refer to this as BCC3 from this time on. So what do we study? Well, from the onset, we felt that it was important to look at all aspects, all factors that will impact a woman's aging. And this includes, of course, cellular and biological factors, which was, I would argue, my area of expertise. Clinical factors such as endocrine health, reproductive health, medications, concurrent conditions or comorbidities. But importantly, and something that had been missing from some of my peers' studies, is the social structural factors such as food and housing security, social support, experiences of violence, stigma, racism, etc. And it's clear that these intersect and influence a women's health and therefore aging, and important to be considered. How the data collection as part of BCC3 takes place in two parts. The first visit takes place in a clinic environment with a research assistant, and we collect the data indicated here, as well as several specimen and anthropometric, the usual data collection and specimen collection. And then within a month, a second visit takes place, either in person and in our case, often on Zoom. And this one is what we call the community visit, which takes place with a community research associate, a woman who has received training in research. And here we look at social demographics, determinants of health, anything from, and you can see the entire list here. We felt early on that it would help to have some material to explain how the study works to participants. And 2 videos were produced by BCC3 trainees and were with input from CRAs as well as feedback from members of the community. The first one was a journey through the BCC3 study, which explains why we're doing this research and what to expect if you are a participant during the BCC3 visits. The second video is explaining what happens to the biospecimens that are collected as part of the study, because we found many participants were curious about it or had reservation about it. And so it explains what happens to those biospecimens, how they are securely stored, how confidentiality is maintained, and what we do with them, which was an eye-opener, I think, for many. And these videos can be found on our website that you can access through this QR code. In terms of recruitment, the study aimed at recruiting 350 women with HIV and 350 controls, HIV-negative controls. Our inclusion criteria are to be 16 or older, or over 16. Cis or transgender women are invited. They must be able to provide consent in English and attend an in-person visit given the specimen collection. We currently exclude women who are pregnant or breastfeeding because a lot of our work has to do with measuring hormones, which would be affected by pregnancy. And importantly, we strive to recruit a sample that is actually representative of the women living with HIV in BC, as well as a control group that is well matched with respect to social demographics and lived experiences with the women living with HIV. So far, recruitment has gone well, but we have some challenge in terms of recruiting youth living with HIV and older women who are African, Caribbean, Black. So if you know people from this community who live in BC, please tell them that we're inviting them to BCC3 if they're interested. Today, we've recruited 75% of our target for women living with HIV, and almost all our controls have been recruited. And these graphs show on top the age distribution of our participants. So you can see that a lot of them are between around 40 to 50 years of age. So in the coming years, many of these participants will be experiencing menopause, which will be of interest for us to continue studying. It's an important part in terms of it affects your hormone, it affects your risk of comorbidities and a lot of other health factors. At the bottom, you can see the ethnicity distribution of our participants, and it closely mirrors the distribution in BC. And as you can see, we are underrepresented when it comes to women, ACB women who are not living with HIV. And I think part of it is difficulty to reach, and some of it is maybe stigma around HIV research. I thought I would present to you the timeline of our community-based research process because it is a challenge. People like me who decide to write a CIHR grant, for example, often don't have really funding to consult with community ahead of time and get their input and do things in a good way, if you want. And we were lucky in a way that with this study, we were able to, in part because we had gotten some funding as part of an LOI for a teen grant to do at the time a pan-Canadian study. So I did fly to several locations and consulted with the CHIWO CRA. I was very fortunate because CHIWO was ongoing, and so I was able to present my ideas and get feedback from women living with HIV about whether they thought it was important and other things that we should consider doing. And then unfortunately, we did not get the funding of the teen grant. So it took a little while. And a year and a half or so later, we managed to get some funding through Project Grant, which really only allowed us the budget to do this in BC. So we we did some focus group early on with women living with HIV to design the study design, review the consent forms, review our surveys, design our logos and all those things. And shortly after, we were able to hire and train 4 BCCRA, so 4 women living with HIV of various age and various ethnicities. And when I say training, you will see in a little while what this means. It was very extensive. Within a few months of all this happening, of course, COVID happened, and while it did stop many cohort studies, we were pretty fortunate that we were able to keep marching forward. We used this time to design our website, pilot our surveys with our CRA, and we did a soft launch of the study in December 2020. And then officially we launched on Women's Day, whoops, wrong year there, 2021. And that was exciting. And it's been going quite well, despite COVID, I must say. At some point, we realized that, of course, most of our participants were from the Lower Mainland, even like Metro Vancouver. So we did expand through a couple of recruitment drives outside Vancouver, one in Prince George, which initially was just a research assistant and a trainee. And we realized that this was, we needed more people, and that the presence of a CRA would have been really beneficial. So the next one in Victoria was including a research assistant, CRA, and trainees. And I would say last year at the Canadian HIV conference, our team presented 14 abstracts. Some of them co-presented by our CRAs. Later in the year, we've been holding brainstorming sessions to try and look at the future of BCC3 and what have we done, and what questions have been raised, and what else would the community help us to study, like us to study. We also did a 2-day retreat workshop outside of Vancouver, where 18 women living with HIV were invited, coming from actually all parts of the province, including Nelson, Prince George, Victoria. We were able to fly them in and host them for 2 days and present some of the findings, but also it was really a bi-directional relationship. Ask them about what they think is important with respect to their aging and what they think we should study next. I will say that as of the end of 2023, we had 593 participants enrolled. And this is really thanks to our amazing team, our amazing staff, amazing CRAs. Throughout this entire time, we had yearly meetings with our community advisory board. We had monthly meetings of the CRA during some of it was for training, some of it was for interaction with the trainees, and as well as bi-weekly BCC3 meetings of the entire team. I wanted to give you an example of how members of the community and the CRAs influence the research we do. First of all, we were asked by members of the community to study pain and chronic pain in women living with HIV. And so we did. And the initial tool that we found was this validated body map of pain locations. And our CRA said, wait a minute, this doesn't represent everything for us. And this is a second additional map that was created with their input that I think is better tailored for women and the various areas where they may experience pain in their body. And indeed, 60% of our participants, when shown the first map, would answer that they didn't have any pain in any of those locations. In terms of the CRA training and our co-authorship policy, basically, first, our CRA are remunerated not only when they administer survey, but also when they undergo training, when they attend our meetings, when they give us feedback, etc. So are Indigenous elders when they open, close meetings, etc. And this here is an extensive list of all the training that our CRA have received. And it's, I don't know, I think it's amazing. It spans everything from the concepts of research and ethics and data quality, how to conduct an interview, how to deal with challenging situations, and those do arise during interviews, how to maintain safety and well-being for not only the participants, but for themselves, how to self-care. I mean, I think our CRA often hear very difficult things during those interviews. How to deal with Zoom, of course, because this is how a lot of our work took place. How to do a oral presentation, and recently had an entire afternoon about descriptive statistics and p-values, and how to interpret an abstract. The CRA came to visit our lab so that they could see for themselves where things are, what we do, and so that they could relay this to participants when they speak with them. They help us, they co-host our cab with us, they've been helping with grant facilitation, etc. For each BCC3 study, our policy is that the trainees should present their ideas at the CRA meeting and team up with the CRA who's interested by the topic, with whom they work more closely, often will co-present with, and who will also co-author their abstracts and publications. We do a lot of knowledge translation and exchange, and this was, initially led by Shada Swan, who's a MD-PhD student on the team. She did many activities. In fact, this is part of her thesis. She did several events with AIDS Vancouver, where women living with HIV are invited, and there's a theme or a topic usually chosen by women living with HIV. And these are 4 examples of art-based events that took place: one on menopause, one on chronic pain, one on cortisol and stress management, and one on resilience and inner strength. And these are examples of the art that was generated by participants during these sessions. Pretty amazing. And different type of arts, so stenciling, drawing, etc. We also have another type of KT event that is led by another PhD student, Tatiana Plevshevna, as part of her public scholar initiative, and also in collaboration with AIDS Vancouver. And these are in-person and virtual events presenting what we call health booklets, as well as Q&A. Each participant receives a health booklet with ahead of the meeting that contains their own personal individual results from our study. So I'm showing you here an example of what would be in a, I don't have enough room to show you the whole booklet, but let's say this is a booklet on liver health. It would first explain what is the liver, what does it do, what are the risk factors for liver damage. In the middle, there's this graph that shows real data from the BCC3 cohort, in this case, FIB4 index, which is a score that represents the likelihood of having liver damage. And if you are in the blue zone, you don't have any liver damage. If you're in the gray zone, it's unclear, but if you're in the orange or red zone, you're either likely to have some or advanced liver damage. And importantly, each woman will have a personal booklet that shows them exactly where they are within this graph. And it's an opt-in approach, so not everybody will get this result, only if they are interested to do so. And on this graph, for example, the women living with HIV are in pink, and the negative controls are in gray. So you can see that there is liver damage in both populations. But and then we explain how to interpret this graph, and then what are medications that may promote liver damage, what would be symptoms, and importantly, we give them tips about how to approach talking with their care provider, be it a pharmacist, a doctor, etc., so that everybody is aware that if they're at high risk of liver damage, maybe some medications should be favored and others not, etc. So the idea is to provide women with agency around taking care of their health. We have other booklets that are upcoming, one on heart health, one on kidney health, cortisol and stress, as well as telomere length. And that one is, and I don't have time to explain what telomere length is, but it's a marker of aging. And this is something that the community has asked us to do. In terms of BCC3 data presentation, I'm not going to give you much results here, but I wanted to stress the point that whenever we present our data, we really try to make sure that each participant is represented rather than summarizing things with boxes and bars. So we try to have a dot for each person. So on the left here is an example of testosterone level in our two groups. You can see there's a slight difference, at least in unadjusted analyses. And on the right, it's a graph of pain intensity and interference with general activities. So on the y-axis, you see the intensity of pain. On the x-axis, the age of the participant. And the color of the dot shows you how much it interferes with their general activity. And you can really see that, each woman is different. And you can see patterns while still showing where each person is. I really want to acknowledge the entire team, the community research associates, the participants, importantly, the investigators, staff, our partners, and the Côté Lab. And here I show you, I hope I didn't forget too many people. They are all the great women on our team. I think we're all women right now. And we have a website, we are on Twitter as well as Instagram. I want to acknowledge our various funders and leave you finally with a list of the many organizations and people who form our community advisory board. And on this, I thank you, and I will stop sharing.
Thank you very much, Hélène, for such a detailed presentation. I have made many notes and have lots of questions, but I will first open it up for questions for Dr. Côté or for Dr. Ross or comments from the audience, which again, you can either put in the chat or put up your hand if you have a question. Or maybe from me while people think about that. That timeline, I counted it up. So you're 6 years from starting with your idea and in the consultation, and you were building upon the infrastructure of the CHIWO study that already had groups of trained and very experienced community research associates across the country. So we as Power are communicating this to research funders. But again, it's an important reminder of really making the case if we want to do patient and person-centered research, if we want relevant research that's engaged with the community, then quite frankly, our funders need to support that research so that researchers and community members can do that in a good way. And that involves both money, but also longer timelines.
Exactly.
Yeah. So.
And it's a challenge. It's a challenge for people who are getting funded through, for example, project grants. That project grants do not give you, early startup budget to do your consultation and to build your relationship. So we were really able to do this because of CHIWOs and because they had started it all before us. And right now, once you're started, we are now able to do consultation for the future project grants. And once the ball is rolling, it's okay. But if you're wanting to embark on this type of research, I agree, it's very challenging without budget, essentially.
To build that infrastructure and those
Yeah.
relationships.
Yes.
Absolutely. Shelley, I see that you have come on the screen. Did you want to make a comment?
No, I just wanted to say amazing presentation to my colleague, Hélène. And Dana, I missed some of yours, but I do have a little question in terms of the difference between focused or informed. And I guess when you're talking about changing things at an institutional level, so that the training is then part of their education. So, for example, whether it's nurses or psychologists, or I mean, I'm assuming psychologists have trauma-informed care training, but just what do you think is the next steps forward to making this become not just a webinar that we talk about, but how do we actually make a change in community clinics, and particularly in the most marginalized, like in Vancouver, in the downtown east side? How do we start to fill some of these gaps that are so glaringly there? What do you think about that?
Yeah, thank you so much. We're thinking a lot about this and sort of wrestling with it in different ways as we think about implementation, both now, but also in future phases. One of the things that we're thinking about at Women's College is, and talking to leadership about, is can we have this actually become part of the onboarding for anybody and everybody who comes on to Women's College Hospital? And I think we actually, that's just one example of doing that, but we need that kind of acknowledgement and implementation and support at that kind of a level. Otherwise, it can't just be, I think, like a thing you could do, or like an add-on module. It's not going to have the power, but it also will have a silent message behind it about the importance of it, or lack of importance about it, if it doesn't have that sort of leadership buy-in as part of the process. So I think embedding it into the onboarding systems, definitely. We hope in our next phase to be able to work with more distinct organizations, like more community health organizations and stuff. And so we'll be talking a lot more and doing focus groups and finding out what the needs are there in terms of these kind of things. But I imagine it will be something kind of similar. One of the things we hear a lot about, not just in this study, but in other studies where we're doing virtual courses, is there's no protected time for people to do this. And so that's another piece as well, as whether that's on onboarding or separately from that. There has to be that buy-in, so that structural, that organizational, that leadership piece. I'm getting more and more and more passionate about that aspect of anything in terms of education for healthcare providers. So that's sort of the initial thoughts that come to mind.
Thank you so much. That's encouraging, I think. And I was just speaking to someone the other day about now CIHR is requiring some courses to apply for grants, right? And I think there's nothing wrong with that. I mean, I just completed 3 courses this weekend that, push comes to shove, I should have been doing. You know, it's something that should be part of my training, and it didn't take forever, you know, and it gave me it was the biomedical data was a bit over my head, but it forced me to do that. And I think, I mean, we don't want to say, maybe force is too strong a word, but it sure is nice to hear the terms, you know, onboarding and getting people to do some work that should be absolutely it shouldn't be a burden. It should be something that you willingly think is important to not only your training and your stage of your career, but your expertise in your job. So I'm very encouraged by that. And I keep learning. And as a community member with an arts background and very little science, and who failed science, it's exciting at this age in my life to be able to learn and to continue to learn. And I think that encouragement in community is something that I think this National Women's Hub grant that's happening right now that's what they're going to be about, is encouraging people to learn. And I think that's really, really important. So thank you both for your presentation. I have an appointment in 5 minutes, so I might have to leave early, and I'll let other people chat. Thank you.
And in case people didn't know or realize, Shelley is one of our CRA extraordinaire, and is now going to be, she's a co-PI, co-principal investigator on a grant that we are applying to next week. hence she had to do the training.
I really liked, Helen, the videos that you had that to explain the study to participants of different folks in different parts of the study. I actually never thought of doing that before, and so now I'm going to take that back to the team as an idea. And to build on what Shelley was saying earlier too, is that I'm talking as a kind of coming to this talk as a researcher, but I'm also thinking as an educator and thinking about the onus coming back on us as educators in this space. How do we make this kind of online asynchronous education engaging, worthwhile, really efficient for people's learning needs, and how do we bring a relational aspect into it? So I think that's another key piece.
Yeah, I think bringing participants their own individual results and how they compare to everybody else in their community. I think that this is something that I think is interesting for them. Certainly, as a participant, I would like to know those things. I would like to, and these are results that they cannot really get from their physicians. Most of the booklets are designed that they're results that only research is able to provide.
We actually asked women if what results they wanted, and telomeres is just the length of their the long terminal repeats on their cells and a marker of aging, and they wanted that information when we told them what it was. True. So so women were excited to get that information when we talked to them. Yeah.
Thank you, Melanie. And the thing is, we wanted those results to be actionable. So we thought we will only give results if our women can do something about it. And telomere was questionable, but members of the community argued that no, it would be motivation to know their cellular age, if you want.
I started out my career as a community-based researcher working in a treatment information program, and at that time in HIV actually, and at that time working to empower people to talk with their healthcare providers. And so when I saw that, I was just so impressed and loved it, and also loved that that's being provided to all of the women in the study, and was very clear in the graph on liver damage that this is something that is relevant to a lot of the women in the study, whether they're living with HIV or not. And so I love that. And what that is truly a benefit of enrolling in the study. Frequently as researchers, I think you think, well, you're giving of your time and your biospecimens really to improve things in a general sense through research for yourself, hopefully, and also for the broader community. But it's rare that people get such an individual benefit from participating in research.
It's true. Very often the research experience is unidirectional for the participants, because what we generate, publications, etc., is not very accessible to them. It's not easy to understand. So we make great effort to generate lay material that is easily understandable, as well as provide these results too, so that really they give to us and we try to give back at the end.
We are at our time, so I will really warmly thank Hélène and Dana for these wonderful presentations that are inspiring in terms of how we can move forward, both in large-scale education to get trauma-informed care throughout our systems, and about engagement of community in research. And I'll let everyone know that we will have another panel to celebrate International Women's Day on March 1st that is going to talk about digital innovations and how they're empowering women across the lifespan. So thank you all for attending today. Much appreciation, and I hope that the rest of your Wednesday is wonderful. Thank you very much.
Thank you.
Thank you.